Hello, and welcome to your third and final part of session 18 for the history of healing. So the science of nutrition has followed two complementary tracks in practice since the mid to late 20th century. There has been a focus on biochemical and other mechanisms involving specific nutrients, and there's also been another focus on the relationship of specific foods and dietary patterns to health and normal development, as well as the use of food as medicine. And both of these things are done by clinical nutritionists. And they both also have covered across other clinical realms and the public health and government settings that we talked about at the end of the last part. So in 1972, the American Nutrition Association formed, and that was an organization that now currently credentials multiple different types of degreed levels of clinical nutrition practitioners, but all of them being degreed leveled. In 1975, the Nutrition Society of Australia formed, and that manages a voluntary registration of nutritionists in Australia. And then in 1986, the American Clinical Board of Nutrition was established, and it certifies healthcare providers who have a specialty in clinical nutrition. So that could be doctors, nurses, etc. So you see there's a number of different or comparative regulatory frameworks when you look across different jurisdictions, looking across America and Australia. And there isn't really a whole lot of formal regulation. There's more association level regulation of nutrition practice in these two countries. So clinical nutrition is practiced on many levels and by many different types of healthcare practitioners in the present across Australia and the US. And that includes clinical nutritionists or just nutritionists, dietitians, nurses, nurse practitioners, medical doctors, naturopaths, naturopathic physicians, chiropractors, osteopaths, and others. And so everyone seems to have their hand in nutrition. And one of the important things about distinguishing oneself as a clinical nutritionist is making sure that you advertise, not the right word, but make sure that you convey to folks who might want to engage with you as a clinical nutritionist that you have a level of qualification that is higher than many in that regard. So one of the specialty areas of nutrition that developed in the late part of the 20th century was orthomolecular medicine and functional medicine. Sorry, these are two different things. I just made that sound like it was the same thing, and it's not. So in 1967, Linus Pauling, who's very well known for his meandering around with vitamin C, coined the term orthomolecular, and that described the alternative practice of administering megadoses of isolated nutrients in supplement form, and that started in the 1930s. And so as a result of this golden age of nutrition science that was happening through the 30s and the 40s, we started having this idea that you could give, it wasn't just about preventing deficiencies, it was and preventing the diseases of deficiency, but that there might be some benefit from giving larger doses than what was necessary to heal a deficiency. So Pauling was one of the most influential scientists of the 20th century, and he used this term orthomolecular to mean the right nutrients in the right amounts to heal certain diseases. And he wasn't just looking at diseases of deficiency, he was looking at all diseases. So early efforts in this area focused on his use of vitamin C, but also niacin in high doses. And one area of focus was mental illness in orthomolecular medicine. And there was some success in that early stage with using high doses of isolated nutrients with mental illness. Since then, orthomolecular medicine has expanded, and it's really blended into the practice of a number of professions, generally in the realm of complementary and alternative medicine. For example, some specialized naturopathic physicians in the US use ultra-high dose vitamin C by IV, intravenous administration, as an adjunctive therapy in cancer. Mainstream medicine tends to criticize orthomolecular medicine as lacking a sufficient evidence base and being potentially harmful. So some folks think the jury is still out. By contrast, in 1990, the concept of functional medicine developed in the US, and this was an outgrowth of conventional medicine merging with clinical nutrition and ideas of holism. So the description of functional medicine, if you look on the Institute of Functional Medicine website, it discusses aspects such as treating the cause of disease, treating holistically the body, mind, and spirit, and in an individualized way, working with genetic influences, environment, and lifestyle, as well as taking a patient-centered approach rather than a disease-centered approach. And some might use this term interchangeably with the term integrative medicine, and certainly it overlaps quite a bit with clinical nutrition practice and naturopathic medicine. Its practitioners are primarily integrative medical doctors, and oftentimes also naturopathic physicians in the US will engage in functional medicine. And the system relies a lot, very heavily, on laboratory testing of genetic and other indicators of each individual's physiological and biochemical weaknesses or deficits as related to nutrient-mediated metabolic processes. So, functional medicine is probably the label that has been applied to this most up-and-coming kind of validation of clinical nutrition in the scientific realm. And it has a lot of concepts that are quite similar to holistic nutrition that we might teach that falls closer to the naturopathic realm. Like the type of nutrition, the holistic nutrition that we teach at Endeavor. It's worth noting that one of the main differences between the two is that there is no mention of vitalism or the vital force or anything like that in functional medicine, whereas that is something that is key to holistic or naturopathic nutrition. So we'll look at that a bit more when we look at our naturopathic lecture next time. We're going to move now to looking at global issues in nutrition, because nutrition is a global issue, and it is a global issue that is a two-sided coin, undernutrition and overnutrition. So we'll focus first on undernutrition. So undernutrition is limiting both to the individual development of a person, and that's clear that if a person is not properly nourished, then their body can't function properly. But it also limits the development of societies and national stability worldwide. And we can see this probably most prominently in Africa, in some African countries where malnutrition is so rampant. But it's definitely a problem in lots of different places. And the results of this are very, very wide-reaching in terms of global health, but also global development and societal development. Recent research quantifies the associations that there are between nutritional status, work, mental performance, and social and economic growth of nations. And so it's important for us to understand that the work that we do in the nutritional realm, as well as the history of nutrition that we are building on, really interacts with global economics and other factors that by which the success of nations is measured, or even the stability of nations is measured. So global food supply is presently adequate to feed the entirety of the world's population, but it is not distributed in a way that accomplishes this. And so as a result, many in the world are undernourished, and they are subject to food and nutritional insecurity. It's very important to point out the fact that this is not true just in underdeveloped countries. There are industrialized, very modern countries in the world where undernutrition in some populations, and particularly in poor populations, is very vitally problematic. And so even in some of the most modern and developed countries in the world, we see issues, especially with children being malnourished and eating things that are too calorically dense and don't have enough nutrients. And so there is still malnutrition there, even if they have enough calories. So we have interventions that are available to us through what we do and also through our activism with governments and such to combat malnutrition or undernutrition globally. We have dietary diversification via education, which certainly is within the purview of, firmly within the purview of nutritional practitioners, nutritional medicine practitioners. We have governmental policies on trade, food distribution, the way farming is subsidized and what types of farming are subsidized, and the regulation of market infrastructures, and I'm talking about international trade as well as trade within a nation. Food fortification, the development of fortified foods, and we're familiar with these in the Western world, like cereals that are fortified with different vitamins. But food fortification in different types of mechanisms, and the use of specific nutrient supplements in areas where folks are missing in specific nutrients, and also public health measures to control disease, because certainly things like infectious diseases will change the needs of a person or a population for different nutrients, and certainly controlling diseases will help to control malnutrition. One example that's impacted undernutrition globally, both in the past and up to the present, is regional military clashes, and over time those have contributed to displacement of people, very large populations of people, with the resulting production of famine conditions. And that's especially true in developing countries in which there is very marginal agricultural production and dietary sufficiency to begin with before the regional military clashes start happening. So it's important to keep all of this in mind if we're thinking about nutrition in a holistic perspective. The image on this slide is from 2012. It is a representation of mortality rates due to malnutrition in the world, and the darker colors are the countries that have the higher death rates, with the lighter countries being ones that have lower death rates. And so there might be some things on here that are actually quite surprising when you look at what countries are dark. We certainly understand the problems with malnutrition in Africa, and those are included here, but we see some dark amber colors and some darker yellow colors in places that we might not necessarily expect to see those in Europe, in North America, in Mexico in particular, but also the United States and Canada are a darker color than we might expect them to be. And then we look at Russia and China being a bit lighter than that. So it's a very interesting thing to look at these food distribution issues and the issues that diet creates even in the most wealthy nations. So overnutrition is probably a bigger problem in terms of disease cause in developed countries than undernutrition. From the mid-1900s, there was a focus of nutrition science and practice away from being entirely on malnutrition and deficiency, and to also focus on the affluent or overabundant diets. And these changes in world nutrition and public health in recent centuries have really created a shift from high mortality, so people dying at higher rates, to high morbidity, so higher rates of chronic disease. And overabundant diets, especially calorically overabundant diets, but also overabundance of things like sugar, salt, and some types of fat are responsible for these things. So with this shift, it was really public nutrition was really dedicated up until about World War II to increasing consumption of meat, milk, and eggs, with the assumption that excess is preferable to deficiency. But then after World War II, when things started to improve in terms of rations and things like that, it was recognized that often the most affluent countries didn't have the best health statistics, and that's still true today, but had diets that were conducive to chronic, non-infectious diseases with onset by middle age. And by contrast, during the war, when European supplies of food were very limited, the incidence of some diseases were actually reduced. And so this idea that we are overfed and that is feeding into our chronic illness began to take hold not too long after World War II. Unfortunately, it didn't take hold enough for us to stop it from developing further. So the changes in recent centuries with this shifting more and looking more at countries where overconsumption and related diseases are more prevalent, it's worth noting that while there are trends that occur by the affluence of the nations, these aren't very cut and dried categories. In many affluent countries, as I mentioned before, we have both overnutrition happening in some segments of the population or in some particular nutrients or some particular food substances like sugar, and we have undernutrition happening with regard to some specific nutrients in those populations, and even diseases of deficiency happening, or chronic diseases that happen from long-term marginal levels of nutrition. In looking at the preventable causes of death that are related to nutrition, these statistics are from, this is a slide that shows how overweight and obesity are, how it ranks as preventable causes of death. So this data is from the US in the year 2000, so it's not super current, and unfortunately it's not local to Australia, but I couldn't find anything similar in the realm of Australia, but certainly we have enough commonalities in our food habits and our disease prevalences that this is probably relatively accurate for Australia as well. So we see here overweight and obesity attributed to be the second highest preventable cause of death, with a number of deaths per year in the US ranking up between 300,000 and 400,000. And you'll note the way that bar is shaded and it gets lighter as it gets taller. The reason for that, whereas all the other bars are solid all the way to the top, is that there's always some question as to what is the actual cause of death in the event of overweight and obesity. Say a woman has breast cancer, and certainly there are studies that are tying very closely the incidence of obesity and the incidence of breast cancer, and that's primarily thought to be due to the production of estrogen by fat tissue and the excess estrogen in the body being problematic in terms of the creation of breast cancer. But we can't say for sure that someone dies of breast cancer, that that's attributable to obesity. And so there's lots of different examples of that. That's just one of them. And that's the reason why that bar is not shaded solid all the way to the top, because it's kind of speculative in many instances. There are some things that can be firmly attributed to obesity and overweight and some that cannot. So about half of deaths currently in people under the age of 65 in the US are estimated to result from diseases in which diet plays a major factor, considered preventable by optimizing the diet. Likewise, the proportion of disease-related disabilities that can be prevented through dietary modification has increased greatly in recent decades as well. So we will leave this topic here to be picked up by your nutrition-specific subjects, because the specifics of dietary recommendations going forward from these early findings and more recent reversals of research in their area are really beyond the scope of a subject called the history of healing, and more the scope of an actual nutrition subject. But suffice to say here that the history is really a cautionary tale in terms of the edict. Correlation does not equal causation. We see this repeatedly in untested theories turning into dietary recommendations. We still see that up to the modern times, and it's very important to use a critical eye when looking at evidence of what things are being caused by nutrition, what things are not, and what things are being helped by nutrition and what things are not. And lastly, we'll touch on cultural attitudes about food. So food is a very unique situation in that it really ties together the intimate, domestic, and familial with society at large, and with institutional and corporate forces that shape and are shaped by individual level processes. So that's a quote from a study in 2014, which you can find in your reference slides, which follow if you want to look into that study more. It's a really fascinating paper on the cultural influence of food. And it's written from more of a sociological perspective and less from an actual nutritional perspective, it's worth noting. So a culture's relationship to food is really inextricably intertwined with the government's regulations around food in that country, the familial and social dynamics and perspectives that surround meal times. For example, do families eat meals together and do they not? The level of interdependence of people within the society or family. Do large families eat together, or are things more fragmented, eating in smaller groups? And the cultures around food markets, the proximity of where people live to farms, and the cultural prevalence of processed foods versus whole foods. It's a very complex dynamic that in many instances has very deep historical roots. And so we think about the cultures that we've talked about throughout this semester and think about some of the attitudes and the practices around foods that come from those cultural roots and the histories of those cultures that end up making a modern mealtime or a modern meal look very, very different across those cultures. I would say also that a person's attitude towards foods, which is very closely tied to the society's views towards foods, can really have a profound impact on health beyond the actual foods that are being eaten. So, for example, if I have taken on board my Western cultural pop culture that says that skinny is best, and I believe that in myself that the food that I'm eating is actually harmful to me, or the food that I'm eating is making me less beautiful in some way, that food is going to have a very different interaction with my biochemistry in my body than it is if I eat my food believing that it is there to fully nourish me and to tie me together with my family and to support all of my body's metabolic processes and to make me strong and active and give me energy. So the attitudes with which we eat food, which are very different across different cultures, are extremely important to how it is that our food nourishes us and keeps us healthy or not. So the last bullet there on the slide, a society's attitudes towards food and culture can have a major influence over health and food-related illnesses. And if you are in a program where you're going to be placing any emphasis on nutrition going forward, I encourage you to investigate the matters that relate to this, because it's a really big thing, and it also really will change the way that you consider your patients if you have patients that are coming from different cultures, where you might have different things to grapple with depending upon what culture somebody is from. So here are your revision questions. This is the end of part 3 and the end of this lecture, session 18. Your revision questions are there as well as on your LMS. And your food for thought: why might it be that the government is directly involved in making food and nutrient recommendations? That's from part 2 of this lecture, but it doesn't generally regulate clinical nutrition practice. So that is a bit of an interesting dichotomy there. So I thank you for joining. This is the end of session 18, and take care.